So just to remind you, about 2% of pregnancies involve cardiac disease, and how I got into it is because most maternal cardiac disease is actually congenital in origin. I mentioned at the outset there's about 2 million Americans now with congenital heart disease, at least half are women, and of course the majority of them want babies. Echo, I think, really plays a critical role in our management at several levels. Pre-pregnancy counseling I'm going to talk about quite a bit, but it's also helpful during pregnancy monitoring. And of course, in the last 20 years, we've learned about fetal cardiac echo. Of course, there's an increased risk for women with congenital heart disease of having a baby with congenital heart disease, and we can do fetal cardiac echoes around 18 to 20 weeks to have a look at baby's heart. And then last but not least, looking at postpartum evaluation. But the real key, and I'm going to share with you a lot of cases, is having the opportunity to get to the patients first with pre-pregnancy counseling. If they've been in the care of a pediatric cardiologist, you'd hope that they were given advice in adolescence at least. But of course, a lot of patients are lost to care. They believe they've had total correction, and many of them present, unfortunately, already pregnant. So pre-pregnancy counseling is the absolute key. And somebody wrote, we all worry about the population explosion, but we don't worry about it at the right time. And having that opportunity to have a good discussion so there's no unplanned pregnancies is absolutely key for the woman with heart disease. You certainly don't want any surprises or mistakes. So let's just recall at the outset the hemodynamic changes that the mother's going to have to withstand. In a normal pregnancy, blood volume goes up almost 50%, heart rate goes up, cardiac output goes up, and the peripheral resistance, as the uterine blood flow increases, peripheral resistance tends to fall. Blood pressure usually stays the same or goes down. Pulmonary vascular resistance goes down, and of course, lots of women get pedal edema. But if you think about those changes, you start to understand what can be most challenging in pregnancy, because if you have a stenotic lesion like aortic stenosis, that fall in afterload is going to make a gradient worse. Regurgitant lesions, on the other hand, they're likely to be better tolerated because of the afterload reduction. So when you're counseling, you have to think about the hemodynamic changes. And one of the things that the guidelines recommend is that we think about this WHO classification risk, which goes from 1 to 4. 1 obviously is relatively benign, but as you get to 3 and 4, you start to worry about increased maternal mortality or severe morbidity. And by the time you get up to number 4 at the bottom, these are the ones in whom pregnancy is contraindicated. And if such a patient does become pregnant, unfortunately, you may have to visit the terrible discussion of termination. So what lesions are we thinking about in these categories? In class 3, mechanical valve prostheses, and in class 4, these are the ones, and I'm going to focus on these and how we look at them with echo. Pulmonary hypertension is number 1. Again, with the volume load, we worry about ventricular impairment, peripartum cardiomyopathy, and again, these symptomatic obstructive lesions, which are likely to get worse. And last, the aortopathies. So I'm going to try and touch on all of these in turn, and I'm going to pepper this with a number of cases. Pulmonary hypertension can really be one of the most scary, and it doesn't really matter whether it's idiopathic or whatever it is, if it's severe. Eisenmenger syndrome are the ones that I face sometimes, and even with all the drugs that we have available to us now for pulmonary hypertension, remember, most of them are contraindicated in pregnancy. And still, even in the current era, these patients have a high maternal mortality, about 30% at least, and they tend to die in the peripartum period. And so you may have a baby and then lose your mother within 24, 48 hours. And of course, peripartum is the time when the hemodynamic shifts are really going wild. And here's an example. Here's a 20-year-old from Burma who had emigrated within the last couple of years, had a history of a murmur and supposedly a normal echo. I don't know if there's any immigrants in the audience like me, but when you come to the States, you clutch your chest X-ray, and look at this chest X-ray. Now, she is just 3 hours post-delivery, and she's in extremis. She's short of breath, hypoxic, and tachycardic. And I draw your attention to not just the pulmonary edema, but look at this humongous pulmonary artery that's clearly aneurysmal along with a big heart. So she shipped in from one of our outreach practices. I tell you, not just was the X-ray bad, and she was bad, and I can't imagine how anybody thought that she had a normal heart, because you put one hand on her chest, she only weighed about 100 pounds, and she had a diastolic thrill, about the most impressive I've ever felt, and there aren't many things that give you a diastolic thrill. So this is her echocardiogram. We're very worried about her. She really is hypotensive, tachycardic. And I draw your attention on the right here, again, to that aneurysmal pulmonary artery. Look at the size of that compared to the size of the aorta. RV is quite hypertrophied. And as we look again at this huge pulmonary valve, and you can see the cause of the diastolic thrill is that she's got pulmonary regurgitation, quite marked. And there's the Doppler, end PR velocity 2.9. So she's got a pulmonary artery diastolic pressure of at least 39 millimeters of mercury. So we're dealing with important pulmonary hypertension. There's the TR, and that confirms RV pressure is systemic, at least. So what's the explanation? Here's the parasternal window, and there you can see she has a huge VSD in the outflow beneath the pulmonary valve with to and fro flow that you see on color. This is classic Eisenmenger syndrome. She should have been advised never to get pregnant, and now she's in extremis, and thank God we were able to get her through with diuresis and pulmonary vasomodulator drugs since now she had delivered, but it was touch and go and frightened me, frankly, and we were lucky to get her through. So counseling would have been ideal before this near catastrophe happened. Let's talk about ventricular dysfunction, the volume load. The guidelines say if the EF is less than 30%, then we worry. But honestly, when the EF is less than 40, patients run the risk of getting volume overload and heart failure. And peripartum cardiomyopathy is a big concern. This is a study looking at the prognosis of cardiomyopathies in pregnancy. And the good news was that about 3/4 of patients recovered, meaning that the EF was more than 50% 1 year after presentation. A number of events and persistent impairment of EF, as you might expect. Interestingly, Black women had worse outcomes with more dysfunction both at presentation and at follow-up. But importantly here, this study does help us with some prognostic echo markers. And I show you this graph. This is looking at what the woman's final status was after a year from the time of presentation based on their initial ejection fraction as shown on the horizontal axis. And they're divided into women who presented with an EF less than 30 versus more than 30. And ideally in this sort of blue lavender color, you'd like to see them recovered. But you see here from this graph that if you presented with an EF less than 30% versus more than 30%, there's a major difference in how many women recover at the end of a year, 37% versus 86%. So if you have an EF that's a bit more than 30%, you have a much greater chance of recovering your EF at 1 year. So that gives us some guidelines from echo. The other thing that's helpful is how big the LV was, and the cutoff here was 6 centimeters. And again, you can see at follow-up, if they were less than 6 centimeters at presentation versus more than 6 centimeters, the size of the ventricle had a much better chance of recovery. And if you combine those two parameters, the EF and the diastolic dimension, if you had both of those at the time of presentation, Not one single patient recovered at 1 year. So echo is very useful in terms of predictors here. And we get asked often, what about a second pregnancy in these patients? That's always the question that we get asked. If the LV function's recovered, is it okay to go again and have a second pregnancy? And what we've learned is there's a low likelihood of mortality if the woman decides to do it a second time, but the second time the EF may go down again and it may stay down. So it's not just will she survive, but the first time may get recovery, the second time you may get impairment, and that may persist. So bottom line, we typically counsel against a second pregnancy. Let's talk about the aortopathies, and we've hammered this, the bicuspid valve and the medial changes. But of course, in pregnancy, again, this is a real concern because you've got that increased cardiac output, but also the hormone changes of pregnancy don't just soften the pelvis, they soften everything in the vasculature, including the aorta. And so that's a concern for the bicuspid valve. And here's an echo from a 28-year-old woman. She's quite asymptomatic, and she wants a baby. And she's got an ejection click and a very soft and brief systolic murmur. And you can see that bicuspid valve there with the raphe, and the valve is doming. And clinically, it's mild aortic stenosis, and the velocity is only 2 meters a second. So maybe she's okay to have a baby. But is she? We start to look, of course, at the rest of the aorta, and as we scan further up, the ascending aorta measures 5.3 centimeters. Of course, it has no relation to the aortic valve disease itself, except that it's bicuspid. So you always have to look at the aorta in this situation, even if the valve function is completely normal. And I'd commend to you the ESC guidelines, not because I was part of them. They're very short, firstly, which is always nice for a guideline. But it says aortic diameters should be assessed, of course, before and during pregnancy. And regardless of whether you've got symptoms, pre-pregnancy surgery should be considered if the ascending aorta is more than 50. So assess the entire aorta. And the guidelines give us, for each of the aortopathies, some contraindication guidelines. So for bicuspid, an ascending aorta more than 50 is a contraindication. For Marfan, it's even more risky, so 45 is the cutoff, or even 40 millimeters if there's a family history of dissection or sudden death. Turner's, because they're usually short, we index the aortic size, and so the index contraindicated if it's more than 25 millimeters per meter squared. Lois Dietz, really scary, 45 millimeters, or again, 40 if there's dissection or sudden death in the family, similar to Marfan. And the really scary ones are the vascular Ehlers-Danlos that are at risk of all kinds of tragedies, including uterine rupture. So for them, pregnancy is contraindicated. So echo is useful here for this pre-assessment, but it's also useful for monitoring during and after the pregnancy. And there are some guidelines telling us where to deliver and how do these women with aortopathies deliver. And this is what the ESC guidelines say, that if you're dealing with one of these aortopathies, repeat the echo every 4 to 12 weeks, depending on how much the dilatation is. And also, after delivery, it's very important too. But look at delivery. If you've got aortic dilatation or a history of dissection, deliver them in a center with a pregnancy heart team, as it's been called, and CT surgery, obviously in case there's a tragedy. And then if the ascending aorta's less than 40, you can do a vaginal delivery, and that's actually safer for all women with heart disease because there's less blood loss. But if the aorta is bigger than 45 millimeters, or you've got this history of dissection, consider a C-section, because you don't want a woman valsalvaing for 24, 48 hours pushing when the aorta is fragile. So for those, consider a C-section, although, of course, the concern about more blood loss. So again, echo is sort of telling you some things about management, importantly, through pregnancy. Let's turn our attention to these obstructive lesions. And For most patients with mild to moderate aortic stenosis, you can usually get them through safely, but like all patients with congenital heart disease, most have never known what normal is. Exercise testing is key and should be done at that pre-pregnancy counseling. And if the AS is moderate, as long as they can do a good functional capacity, no ischemia, good rise in blood pressure, and so on, you'll usually get them through. But for severe AS, this is a big nightmare, and you should intervene before pregnancy. And this is what the guidelines say: intervene before, if they're symptomatic, if the EF's less than 50, or if they get symptoms during an exercise test, and intervene if they get a fall in blood pressure below baseline when you're doing the exercise test. So let's take some cases. Here's a 23-year-old who had no pre-pregnancy counseling, and of course, 22 weeks pregnant, as that volume load is starting to go up, she's short of breath. Now, this valve looks mobile. It's bicuspid. Again, you can see this raphe about 2 o'clock. But that doesn't help you with anything, because her peak gradient is 118 millimeters of mercury. And at 22 weeks, even before she hits peak volume, she's in trouble. So what choices do we have with this patient? This is a pliable valve. One of the things you can consider in experienced centers is to balloon a pliable valve, and we asked Dr. Nishimura, would he just balloon it just perfectly, so he didn't blow the whole thing and give her severe AR, but enough so we could get her safely through the pregnancy. And as instructed, that's what he did, and got the gradient down to about 45, and we were able to get her successfully through the pregnancy. So that's one option you can consider. But here's a different one. This is a 47-year-old Amish lady who hasn't seen a doctor for about 5 years. She's already 22 weeks pregnant. It's her 11th pregnancy. And for about the last year, she's had some chest pain walking around, and now she's pregnant, it's getting worse. And actually, as she walked across the clinic just about 10 yards, she was getting angina. So you look at this echo, and you can see this valve is a different story. It's doming, and it's very lumpy, and she's got a happy ventricle. But this, too, is a bicuspid valve, but a different sort of kettle of fish, although the gradient is 129 peak. And so what can we do with her? When the valve is thick and probably calcified like this, very worrisome to consider balloon valvuloplasty, and Nish wouldn't speak to the whole thing. So we ended up doing a valve replacement in her with a tissue prosthesis at about 25 weeks of pregnancy, and happily got her through. And we've learned a lot of ways to get people safely through pregnancy and surgery, which we could perhaps discuss, but it's not something we like to do because there's obviously risk to mother and to baby. But happily, we had a good outcome for both. Let's turn our attention to a different valve. Here's somebody who's in your emergency room, now 32 weeks pregnant, dyspnea, palpitations, JVP's elevated, tachycardic. She's got a loud S1, an opening snap, and a diastolic murmur, and she's in pulmonary edema. So take a look at this mitral valve. You see a lot of stenosis here, mean gradient 15. What to do? Any interventionalists in the audience? Well, you could consider ballooning because it's a pliable valve, but in fact, the treatment of choice in this situation is to slow the heart rate down. And here, with the slower heart rate, gradients 4 at a heart rate of 60. So beta blockers in this situation for mitral stenosis are the mainstay of therapy, and you only resort to doing a balloon if you absolutely have to, and patients are refractory to even high doses of beta blocker. Slow the heart rate down, and chances are you'll get the patient through safely. Lastly, let's turn our attention in the last 6 minutes or so to mechanical valve prostheses. And of course, again here, echo is really integral because we need to look at the valve and the motion. And what's very helpful is to have that fingerprinted echo that you hopefully got at the time the patient was being dismissed from hospital after their first post-op procedure. And again, if you've had a chance to do pre-pregnancy counseling, get the baseline and see whether the valve is working properly. It's all about your detective work. So let's take another case. This is a 30-year-old woman, this time has rheumatic disease. She'd had one mitral valve repair, which didn't work. In 2004, she had a tissue mitral valve, and after that had one successful pregnancy. But of course, in young women, they degenerate their valves fast, and so in 2016, her valve had degenerated, and she had 2 mechanical valve replacements, both mitral and tricuspid. In 2018, she's doing well, has an echo, asks advice about pregnancy, so there's a question coming up. She's on 5 milligrams of Coumadin a day, stable. Mitral valve gradient is 4. Tricuspid valve gradient is 2. And so my question for you is this: which of the following anticoagulant strategies is safest for the mother? Change to sub-Q low molecular weight heparin, 1 milligram a kilogram for the first trimester, avoiding concerns about embryopathy, then back to warfarin. Change to sub-Q low molecular weight heparin throughout pregnancy, or continue warfarin. Please vote. Anybody voting? Okay. Okay, good. So let's see. Okay, so most people want to switch it to low molecular weight heparin for the first trimester. So let's look at this and we'll see actually what happened to her. So her Coumadin was stopped as soon as she was pregnant, and she was changed to Lovenox 80 milligrams BID. About a week later, she started to get tired and more short of breath, and a week or so after that was much more short of breath and quite sick and got transferred to us. JVP is now elevated. There's a prominent RV impulse. Apical mechanical sounds were crisp. Tricuspid sounds were muffled. And there's a murmur of TR. And here's her echo. So we're looking at the mitral valve. And of course, it's tough. Pregnant echoes are tough. But I think you can see the mitral valve leaflets on the right seem to be moving. We're focusing in on these again. Think the leaflets are moving, and there's the mitral gradient is 2. So we're a bit reassured. Let's turn our attention to the tricuspid valve. A little bit more difficult. Can't see so much leaflet motion. A bit turbulent on color. Tricuspid valve gradient 15. So no wonder the JVP is elevated, and we've got an RV heave. So what to do now? Well, of course, we've got lots of trials now about TPA. Can we use this in pregnancy? Can we thrombolyze this tricuspid valve that's already thrombosed? And the answer is we can, because these are big molecules and they don't cross the placenta. So that's what we did. We did every 24 hours an infusion of TPA and re-echoed. And here we are at day 3, looking at the tricuspid valve. It looks like it's moving better, and now the gradient is 2, and so happily we got her through. So let's just touch on this in the last 2 or 3 minutes. You were worried largely about warfarin embryopathy, and of course we worry about this because vitamin K antagonists cause problems with development, and they also, even later than the first trimester, cause hemorrhage. But what we've learned is that the risk is dose-dependent, and the risk is low if the mother's on 5 milligrams or less of warfarin a day. And we've also learned that warfarin is a much better anticoagulant than heparin. And this is what the guidelines say, both ACC and the European guidelines. There's reasonable concordance that if the mother's on 5 milligrams of Coumadin or less in the first trimester with much discussion, continue Coumadin. It is safer. If she's on more than 5 milligrams of Coumadin, you can consider heparin, unfractionated, seldom used now, or low molecular weight, with asterisks, and that means monitoring. In the second trimester, when you're no longer worried about embryopathy, Coumadin should be used, and if you choose to use heparin, it's a 2B indication. And in the third trimester, you have to get these women on unfractionated heparin, and you can't deliver on warfarin or heparin because the baby will bleed, and of course the baby's anticoagulated on warfarin. So if you use heparin, whenever you do it, you change in hospital and you need to monitor anti-10A levels, and you never do weight-based dosing. This is a composite from the Seattle group looking at outcomes, 800 pregnancies, looking at maternal death, valve failure, thromboembolism, fetal death, or spontaneous abortion. And this is a nice pictorial to share with your patients. This is risk of maternal or fetal event. Vitamin K antagonists, 44%. Low-dose warfarin is the best, still 20% risk. Heparin, however you use it, is worse. And this composite doesn't include things like hemorrhage, fetal intracranial hemorrhage, and neonatal death. So it's a risky business. There's no perfect solution, but the bottom line is low-dose warfarin is much better for mother. And in the pregnancy issue, it's a sort of double jeopardy as we consider there is a risk to baby, not just the embryopathy, but fetopathy with placental hemorrhage, cranial hemorrhage, and so on. But heparin is a much worse risk to the mother, so you have to balance these risks and obviously shared decision-making. And in a recent registry, you think about what's the risk? How are we going to get the mother through? 90% success, 80%, only 58% of pregnancies were free of serious adverse events. These patients need to be managed in special centers. So in summary, there are these high-risk lesions that we worry about that I've gone through, and really patients should be managed before they get pregnant, and pre-pregnancy counseling is key. Mechanical prosthetic valves, there's no perfect solution. Have a pregnancy heart team involved with meticulous monitoring and echo assessment, particularly at the time of pre-pregnancy counseling, is absolutely key. Most women would say, though, at the end, it was all worth it. Thanks very much.